Good morning, everyone. Today we are going to start the next episode of the 3,000 question series we've begun. But before we start the next episode, I'd like to share some more good news with you. And that is, we're starting a 100-day challenge. In this 100-day challenge, we'll be holding a 1 to 2 hour class every single day on this YouTube channel, so that over the next 100 days, we can discuss all 3,000 questions. So this is a challenge, and for this challenge, you'll need to attend classes on this channel every day for the next 100 days. If you do this for the next 100 days, if you attend 1 hour classes every day on this channel, you'll be able to practice 3,000 questions. So you must accept this 100-day challenge. And for the next 100 days, you'll find classes here on our channel continuously. So let's start with today's first question. A nurse is caring for a client diagnosed with hyphema. Hyphema is a condition where blood collects inside the anterior chamber of the eye. Following a blunt ocular injury, which of the following nursing interventions is the priority to prevent further ocular complications? This means to avoid more complications from this disorder, what should the nurse do? Now, what exactly is this hyphema? We need to understand this first so that we can solve all the questions related to hyphema. Look, these are our normal eyes. Now, as soon as an injury or trauma occurs, the blood vessels inside the eye will get damaged. Because of that damage, blood will start collecting right here. Blood will start collecting in the anterior chamber of the eye, and this is what we call hyphema. Okay, so this condition is called hyphema. If I show it here, like this eye, if I show you its cross-section, so in this, the anterior chamber of the eye, this anterior chamber, meaning the iris and cornea portion between these two, is what we call the anterior chamber. So when blood collects here, due to trauma, bleeding occurs and blood collects here, and that's what we call hyphema. Why is it called hyphema? It's because, look, as you saw here, the blood is collected at the bottom, not at the top. And in this diagram too, you'll see the blood is at the bottom, not at the top. So for below, we use the word hypo, and for blood, we use hemato. So now, from these two, they combined some words to name this disorder. They took HYP from here and HEMA from here. So if I combine these two words, it becomes hyphema. So hyphema is a disorder where blood collects in the lower chamber. Hypo means below. So the collection of blood within the anterior chamber of the eye is called hyphema. If we understand its physiology and pathophysiology, we can easily solve any question related to hyphema. Now, let's see what happens if there's bleeding inside the eye. So this bleeding has collected in the anterior chamber. Now, we also need to see that this part is called the iris, and this is the cornea. An angle forms between them, which we call the iridocorneal angle. The iridocorneal angle. This angle formed between the iris and the cornea is what we call the iridocorneal angle. This angle is very important because, as you'll see when I enlarge it, there's something underneath it. You can see a network-like structure here, like a mesh or a grid. That's what you'll see. We call this the trabecular meshwork, this mesh-like structure you see here. This is the trabecular meshwork, and beneath this trabecular meshwork, there is a canal called the canalus schlemm. This is very important. Normally, what happens is that aqueous humor is produced by the ciliary body inside our eye. Once that aqueous fluid is formed there, it flows out from that area and enters the anterior chamber. In a normal condition, assuming no bleeding has occurred, this aqueous fluid moves toward the front. It then passes through the trabecular meshwork into the canalus schlemm and enters the systemic circulation. However, in the case of hyphema, which we know means blood collecting in the anterior chamber, if blood collects here at this angle between the iris and the cornea, then look, it'll get stuck inside this meshwork, and once it's stuck, it'll cause a blockage. If the trabecular meshwork gets blocked, or if blood collects in this angle and blocks it, then the aqueous fluid coming from here won't be able to move forward into the systemic circulation. If it can't enter the circulation, it will build up here, filling this area first, then this one, increasing the pressure. After this, it'll push the lens backward like this. It'll push the lens back. If it pushes the lens back, then inside this chamber already contains vitreous fluid. Now, when it pushes the lens back, pressure will be applied to the vitreous fluid, and it will apply this pressure here. This pressure will go all the way to the back, and that's where the optic nerve is. More pressure will be applied to this optic nerve, and due to the increased pressure on the optic nerve, it will get damaged. Because of this damage, blindness will occur here. So whenever there's a Hyphema patient, when we manage them, we must keep one thing in mind. There's a higher chance of increased intraocular pressure in this patient. Therefore, we need to do things such management so that the intraocular pressure doesn't increase. So now what happened is, if the aqueous humor couldn't drain back from here, the pressure here will increase. It pushed the lens back, then the pressure here will increase, and this increased pressure will damage the optic nerve. This leads to a risk of blindness in the patient. So one of our focuses should be that the intraocular pressure does not increase. Besides this, we must remember one thing. This blood is at the bottom, okay? If it's at the bottom, we need to ensure that this blood doesn't move further forward to this area. If this blood comes forward, if blood comes here, it will be in front of the pupil. If blood comes in front of the pupil, the light rays coming from here won't be able to go inside. This means the patient will have vision problems, okay? So we also need to keep in mind that we have to save the vision. We need to consider these 2 or 3 things from here. Now let's look at its management. One thing we need to keep in mind is that when bleeding occurs here, a clot will start to form. The formation of a clot is good for us so that the clot forms and prevents further bleeding. Now, we must also save and protect this formed clot. If this formed clot gets disrupted or breaks down, the chances of rebleeding will increase. Therefore, we must not allow any movement. Now look, if there's too much movement inside the eye, what will happen? If there's too much movement, then suppose a clot has formed here. If there's too much eye movement or movement of the iris or the ciliary muscles, it will be disrupted. Being disrupted, there will be chances of rebleeding again. So remember, we have to protect any clot that's there. We must not let it break. So that's why we shouldn't allow movement. So that means we have to protect the eye. Now let's look further into this. Besides this, let's talk about the options and what will happen. So the first option given here is to apply a protective eye shield over the affected eye. That is, we need to put a shield over our affected eye. Applying a shield will provide protection, but without pressure. One thing you must remember is that whenever you're managing hyphema, you shouldn't apply pressure like this on the inside, because if you apply pressure on the inside, this pressure will go even further. If the pressure goes further, it means the IOP will increase. So we need to protect it, but we shouldn't apply pressure. For this, we have 2 options, whether you'll apply a patch or a shield. So many students choose the patch option as correct because when we see what a patch is, this one is a patch. So when we apply a patch, we'll get protection, but pressure will be applied because it comes in direct contact with the eye. It will come in direct contact with the eye, so then pressure will be applied. If pressure is applied like this, then the pressure will increase even more. So the patch is this one, and it comes into direct contact with the eye like this. When we've applied it like this, see what it did? It applied pressure on the back side. So it protected it, but applied pressure. So that's why we want to apply this. Now what we'll do is give such protection that doesn't apply pressure. So look at this. This one is an eye shield. Look at it from the inside. It's hollow, meaning concave from the inside. It's concave on the inner side. So now if we apply this over the eye, putting it like this, and if we put it here, this one. So what will happen with this is protection was gained, like we applied this. Now see, it has gotten protection, but along with getting protection, it hasn't touched the eyeball directly inside. If it doesn't touch the eyeball, it means it's not applying pressure on the inside, but it's giving it protection. The purpose of applying this is so that there's no movement inside the eye. If in the eye, because if nothing is visible from the outside, then there won't be movement. If there's no movement, then the internal clot won't be disrupted. So what you always have to remember is whenever there's hyphema, you have to protect it. Protect, but without pressure, okay? So now let's look at the first option. Apply a protective eye shield over the affected eye. Okay, what do we have to do? Apply an eye shield. So this one will be its correct answer. Second option, position the client in a flat supine position. Supine means that if there's a patient, we'll lay them on their back. If we lay them on their back, then their face would be facing upwards. If I lie down like this, then my this will be like this and my body will come like this. This means we'll have this problem because I told you one thing, that this blood, we have to keep it settled down at the bottom so that it doesn't come up. It doesn't come in front of the pupil. If it comes in front of the pupil, then the patient will have vision problems because there are light rays inside. Light won't be able to go inside. If we lay the patient supine, supine means laid on the back. As soon as we lay them on the back, then what will happen? It will be like this. If it's like this, then the blood, it will spread from here and into the entire pupil like this. The blood will spread in front of the entire pupil like this. Now, if blood happens to spread out in front of the pupil, then the light that normally enters the eye just won't be able to go inside as it should. So the patient will end up having vision problems as a result. That's why we have to keep the patient in a high Fowler's or semi-Fowler's position only, so that the blood remains settled at the bottom. So here, this will also be an incorrect option. Besides vision, there will be one more problem in this. If, suppose, you've given the supine position to the patient, if you give the supine position, right now, see, gravity is acting on this blood, so it's going this side. Gravity, this blood, gravity is pulling it downwards, so it means now the pressure is going this way. But if I lay them down like this, it'll be on top and blood will collect here. And if it's on the upper side, gravity will pull this blood down like this because it's in this position now, so it'll pull it down. Now more pressure will be applied, which means IOP will increase. So laying them in a supine position will have two disadvantages. First, the patient's vision will be affected because blood has come in front of the pupil. Second, it'll all get distributed across the entire iris and throughout the anterior chamber here. Because of that, due to gravity, more pressure will be applied, so IOP will increase, which is something we don't want. So that means this will also be incorrect here. Next option. Anticipate administration of acetylsalicylic acid for pain control. Acetylsalicylic acid is another name for aspirin, and aspirin is an antiplatelet drug. And an antiplatelet drug is a drug that, well, it doesn't let platelets aggregate, it doesn't allow clot formation. So the thing is, we actually want a clot to form so that there's no further bleeding and IOP doesn't increase, so intraocular pressure doesn't rise any further. That's why we won't give this here. If the patient is in pain, we can give paracetamol, but we won't give aspirin. Next option, apply a pressure eye patch over the affected eye. Apply a pressure eye patch over the affected eye. This is exactly what we saw, and it's mostly an NCLEX trap. What students do is they select this one because it's an eye patch, so they think it'll protect. But you have to remember, we need to protect it, but without pressure. An eye patch comes into direct contact with the eye, so it applies pressure. That means this will also be wrong here. So far in Hyphema, you've seen that Hyphema means blood in the anterior chamber of the eye. If there's blood in this anterior chamber, you need to keep two things in mind. First, the patient's vision shouldn't be affected. Second, the patient's IOP shouldn't increase. If you keep these two in mind, third, you also have to prevent rebleeding. This means that now, with this, if any question is asked related to Hyphema, you'll be able to clear it easily. If you just keep guessing and memorizing things, then if a question other than this one comes up, you'll get stuck. But if you studied this along with the full physiology and pathophysiology, then no matter what question is asked from this, you'll know. If I were to ask you now whether we can give the patient atropine, suppose an option comes up here, can we give atropine? If you've only memorized the question and solved it from there, thinking you'll just guess the answer, then you'll only be able to solve this specific question if it shows up in the exam. But if the examiner puts an option here like, can we give the patient atropine? Or can we give tranexamic acid, Tranexa? So now you have to keep this in mind. If you want to see the whole picture, you need the full physiology and pathophysiology. If your concepts are clear, you'll be able to solve any question. The lecture will be a bit long. It might go on for 2 hours or even longer, but all of your concepts will become clear. After that, you won't get any question related to the eye wrong. So you need to remember that whenever there's a hyphema, you can give these drugs, A, B, C, D. I'll explain A, B, C, D just to help you remember. One thing you must keep in mind is that we should never let the patient strain, because straining causes eye movement, so avoid straining. We must also prevent the patient from coughing, because coughing increases pressure and the clot could break. So we need to avoid such activities for the patient. Besides that, A, B, C, D, meaning these are the medications we can give. So what are they? A stands for antifibrinolytic. Look here, this fibrino and this lytic. Lytic means breakdown. Breakdown as in something that breaks things down. And fibrino refers to fibrin. And anti means against. So now you have to remember that we can give medications that work against the process of breaking down fibrin. In other words, we can give medications that act against those that break down fibrin, such as Trenexa. Tranexamic acid is a drug. What tranexamic acid does is it helps in the formation of a clot, okay? So, for example, we can give Trenexa. Tranexamic acid. This is an antifibrinolytic medication. Besides that, for B, we can give the patient beta blockers. Beta blockers work inside the eye to reduce intraocular pressure because they decrease the production of aqueous humor, so the IOP won't increase. This means beta blockers will work to prevent the vision loss the patient was experiencing. What they do is they reduce the production of aqueous humor from the ciliary muscles. If this is reduced, then even if there was a blockage due to blood, since there's less aqueous humor, it will exert less pressure. This reduces damage to the optic nerve, so the risk of permanent vision loss for the patient will decrease. So we need a medication that reduces the production of aqueous humor, and that's where beta blockers come in. Among beta blockers, we can give Timolol. Next is C. For C, we'll give cycloplegics. Cycloplegics are medications that paralyze the ciliary muscles. If the ciliary muscles are paralyzed, then regarding these cycloplegics, I asked you a question earlier. Can we give atropine to the patient? In Hyphema, the answer will come from here. What will cycloplegic meds, these cycloplegic drugs, do? They will paralyze the ciliary muscles. Because of that, there won't be any movement here now, because if, let's say there's bleeding here, the patient will feel pain. There's a spasm inside. If there's pain and a spasm, the iris will move. If the iris moves, then there's a chance this clot will break. So to protect the clot, we have to prevent movement inside this eye. We must prevent this movement, the internal movement. So what we'll have to do is give medication that paralyzes the ciliary muscles, which are cycloplegics. If we look for an example of this, it's atropine. This means we can give atropine to the patient. After this, D stands for Diamox. Diamox, which is also known as Acetazolamide. What will Diamox do? Diamox also reduces the intraocular pressure inside. So that's why Now, if someone asks you if we can give atropine, yes, we can give atropine. If they ask if we can give Timolol, yes, we can give Timolol. Can we give tranexamic acid? Yes, we can. Can we give Diamox? Yes, we can. But we cannot give aspirin. So you have to remember this.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course. The link is in the description. Now, let's continue with the topic.
Next question. The nurse is assessing a client with a suspected retinal detachment, meaning there's a suspected retinal detachment. Which of the following manifestations would not be consistent with a diagnosis of retinal detachment? This means the patient might have a retinal detachment, and we need to find which symptom is unrelated to it. It's a negative question, see? Would not be consistent with the diagnosis of retinal detachment. So our answer will be the one that is not a symptom of retinal detachment. That will be the correct choice here. First, the presence of floaters within the visual field. What is a floater? It means it feels like small things are flying in the visual field, like tiny flies are buzzing around. Let's first look at all the symptoms, and then we'll eliminate them so you can understand it clearly. So this thing here, see, this outermost one is what we call the fibrous layer. The middle one is the choroid layer, which provides nutrition. The innermost one is the retina. This retina is pushed by a fluid called the vitreous fluid. It's found in this part and it pushes it toward the back like this. Because of this push, the retina stays firmly attached to the choroid. But as we age, this fluid decreases. It gets less. So that means whenever there's movement, that fluid will pull it toward itself. When it pulls, at that exact moment, what happens is an impulse will be generated, a visual impulse will be generated. And the brain will think it saw some light there. So normally what happens, the vitreous fluid decreased, the fluid decreased. So because the fluid decreased, it pulled this retina toward itself, toward its side. As it pulled it, there was movement there. When there was movement, a visual impulse to the brain, so the brain thought there were some flashes of light. I want to show it like this. For instance, if I turn off the light, it feels like, let's say, some light is falling from the front. Even though there was no light, the patient feels this. It will happen at this time. As soon as there's movement in the vitreous fluid, meaning the patient moved their head, then what happens is it feels like flashes of light are hitting them, even though there was no such visual on the outside. No, only the patient feels this. There was no such light in front of the patient, but the patient felt as if someone was flashing a light directly into their eyes. Why did that happen? It happened because the vitreous fluid decreased. It got less. The vitreous fluid was attached to it and it decreased. This means it's no longer fitting properly inside this chamber. So when the head moved or whatever happened, the vitreous fluid shifted. As the vitreous fluid shifted, it pulled this toward itself. Upon pulling, an impulse was generated here and went to the brain. So it felt like flashes of light were occurring. So we call this flashes of light or photopsia. In this, there was actually no light available on the outside, even if it's pitch black. Even then, when the patient moves, they'll feel like flashlight flashes are being aimed at their eyes. So this symptom will be present. In this case, it means we now have to eliminate it, because this question asks which one is not a symptom of retinal detachment. So flashes, which we also call photopsia, let's eliminate this. So here it is, and we've eliminated it because it's actually a symptom of retinal detachment. But the question asked which symptom is not related to retinal detachment. After that, we see that this is the very first stage. In the early stage, the patient experiences flashing. Now, what happens next, if it's not managed, the retina will start to detach. A tear will form in the retina. So what happens is that a tear starts to develop within this retina, and once it tears, the retina becomes damaged. Just like that, the retina tore and became damaged. See, the tear happened right here. The second stage is when this tear occurs, the retinal cells from here, these retinal cells, turn into debris and enter this area, meaning they start floating around inside the vitreous fluid. They start floating in the vitreous fluid. It's possible that some blood cells from here also enter, so blood cells also start floating, or rather drifting around in it. So these are the blood cells. Since they float, we call them floaters. Do you know what happened before they were there? Normally, if these things aren't present or if they're absent, what was happening? When light rays entered, they would pass through and immediately reach the retina. This means whatever was being seen was clearly visible. Light rays came in from here and easily reached the retina. But when the retinal tear occurred, meaning a tear started inside the retina, because of that tearing or rupturing, debris started entering here. The retinal cells that broke off ended up inside. Now, see what happens. The light rays coming from here, this light ray, hits this. It can't go any further because this debris blocked it right here. So the light ray that was supposed to hit the retina now creates a shadow. This means no light rays reached here, so a shadow is felt in this area. The patient feels that in the area where the light rays were coming from, they see a shadow outside. Because these light rays were supposed to reach the retina to show something, but the debris in the middle blocked them. Since they're blocked, there's a shadow here. A shadow here means the patient sees a shadow outside. Similarly, a light ray comes from here, and this light ray hits this debris. Since it hit the debris, the light ray didn't reach the other side. So there's a shadow here, and then the patient feels there's a shadow outside. The light rays that don't hit this will easily reach the retina. Light rays came from here, and those that didn't collide with the debris reached the retina easily, allowing the patient to see. Now, this debris inside is what we call floaters because they float around inside. So this means a patient with retinal detachment also has floaters. But this isn't an early symptom. The early symptom was flashing of light because at that time, retinal detachment hasn't occurred. I want to show you how this mostly happens with an example. Think of this thing like this, as if the water inside is the vitreous fluid inside the eye. Consider this the eye and this the vitreous fluid. And what happens in this is that as soon as our retina breaks or detaches, now watch, the retinal cells break off like this. So from the top, from the detached retina, cells and debris come down like this. See? They are floating. That's why we call them floaters. These are floaters, see? They will float in it like this. Like this. Like this. Now, the more movement we have the patient do, the more they will float. So in retinal detachment, it's our responsibility to minimize the patient's movement. Now look, if it's like this, there's less movement. But if there's more movement, look, they float again. If there's even more movement in the patient's side, then this debris will float around like this. That's why in a patient with retinal detachment, when these floaters are found, we have to restrict the patient's movement so that further detachment doesn't occur and the patient's vision is preserved. So this means floaters are also a symptom of retinal detachment in a patient. So now we have to eliminate this here. Where are the floaters? Here it is. Presence of floaters within the visual field. This means it's found in retinal detachment. But the question asks for what is not a symptom, so this will be wrong. After that there's one more symptom in this. Now, when a tear occurs in the retina, as soon as it tears, the retina tears first, and after tearing, it detaches from here. It detaches and hangs down on this side like this. Now that it's hanging separately, look, it's moved away from the choroid. This part is still closed, so it's getting nutrition from the choroid, but this part has moved away and isn't getting nutrition. Due to the lack of nutrition, these cells will start getting damaged and will eventually be completely destroyed. Now, if any light rays fall on these cells, no signals will be generated because these cells are completely damaged due to lack of nutrition. If they are damaged, then no matter how many light rays fall in this area of the visual field, meaning the light coming from outside, the patient will feel as if a curtain has been drawn here. They won't see anything at all. The patient feels like a curtain is being drawn across their vision from the side, like this. In this, the patient feels like a curtain is being drawn from the side across their eyes, like this. So this is mostly found in retinal detachment. This means we call it, so let's see, if this is also in the options, we'll eliminate it too. Sensation of a curtain descending over part of the visual field. Yes, this is also found in retinal detachment and it's found in the late stage, so we'll mark this one as wrong too. Last is severe ocular pain in the affected eye. Severe ocular pain in the affected eye, this is mostly seen in glaucoma. Because there's more pain in that, the pressure increases. So what happens inside is that there's a sensation of pain, whereas it doesn't happen in this. So the correct answer here will be this one, which is severe ocular pain in the affected eye. A client presents with acute angle closure glaucoma, and an intraocular pressure, IOP, of 40 millimeters of mercury. 40 millimeters of mercury, which is much higher than normal. Normal is 10 to 20 millimeters of mercury. Intraocular pressure. This is very high, which means it's an ocular emergency. What medication should the nurse anticipate first? So, which medication will the nurse try to give first? Look, IOP, we've seen that glaucoma means an increase in intraocular pressure. And what happens is that here, our canal, which we've already studied in the previous question, this canal was draining from here. Now, what will happen is that this angle closure, it says acute angle closure. Angle closure means that this angle, the angle between the iris and the cornea, has closed like this. If it's closed, it means drainage can no longer occur from here. Okay, this angle is now holes like this. Now, if this angle is closed, drainage won't be possible. And without drainage, the pressure increases here, the intraocular pressure increases here, and the pressure increases here as well. This is what we call glaucoma. And if it's due to angle closure, it means it's a serious condition, and the intraocular pressure will rise very quickly. Now, let's look at the options to see which medication we'll give first. Since this is an emergency, we need to select a medication that works quickly. Timolol. Timolol, anything ending in lol, is a beta blocker. And whenever we give Timolol to a patient, it works on the ciliary body. By working on the ciliary body, it reduces the production of aqueous humor. Now, less aqueous humor is produced here. This means the intraocular pressure won't increase further. But this effect happens gradually. We need a medication that works immediately. Timolol will lower intraocular pressure, but the effect is quite slow. Next, let's look at Mannitol, option B, IV Mannitol. Mannitol is an osmotic diuretic. This means it creates osmotic gradients. When we give IV Mannitol to a patient, it travels through the circulation and reaches the blood vessels inside the eye. Suppose these are the blood vessels. Now Mannitol has arrived. If Mannitol is here, labeled as M, it means the blood here has become concentrated or thick. If the blood here has thickened, the concentration has increased. Now, osmosis will begin. In osmosis, water moves from where it's more abundant to where it's less abundant, or we can say water moves toward where the solute concentration is higher, like here. And where does it come from? From where the solute concentration is lower. So just remember that there's more water here and less water there. Because mannitol is present, the blood here has become very concentrated. Since the concentration increased, osmosis occurs. Now, water from this aqueous humor will move here. As this water enters, if a lot of water moves into it, like this, then the volume of the remaining vitreous fluid will decrease. If that volume decreases, it means the pressure here decreases. So the pressure that had increased here due to glaucoma, meaning the pressure increased because the aqueous humor wasn't draining. This pressure was pushing backward and increasing the pressure here. So this immediately compensated for it. It reduced the amount of vitreous fluid here. As a result, the pressure coming from this side can no longer press against the optic nerve because the amount of vitreous fluid here has decreased. This happens very quickly when we give mannitol. This means we give mannitol in emergency conditions. It's an osmotic diuretic and works through osmosis, so it works immediately. In an emergency, we give mannitol. As you saw, the IOP is over 40. Since it's over 40, the optic nerve can be badly damaged if we don't act fast. So we give IV mannitol. Atropine, what does it do? Atropine will dilate the pupil. Atropine will act on this iris and cause pupil dilation. Now look, If atropine dilates the pupil, whenever the pupil dilates, it bends forward like this. And if it bends forward, the pressure inside will increase even more. So we won't give atropine in glaucoma. Right, because if we administer atropine in glaucoma, it causes pupil dilation. It's a mydriatic, and we never give mydriatics in glaucoma. You might wonder why we used it for Hyphema before. The reason for giving it in Hyphema was different, because in Hyphema, this angle isn't closed because of the iris. As we saw in the previous question, the angle in Hyphema was actually perfectly fine. But blood had gathered there, and once that happened, it ended up blocking the canal. It blocked the trabecular meshwork, that mesh-like structure that acts like a filter. In that case, the angle was completely fine, meaning the angle between the cornea and the iris was okay. But blood got in there, and that blood is what blocked the trabecular meshwork. Now, in this current condition, the angle is already closed. If we give atropine, it causes mydriasis. When mydriasis occurs and the pupil dilates, it makes things even worse. The iris moves forward like this. Since the angle is already closed, as we discussed, this movement will just make the whole situation much worse. Unlike what we saw in the previous question about Hyphema, so why do we give it for Hyphema? Well, our reason for using it there was completely different. Atropine was different because in Hyphema, we paralyze the ciliary muscles. It's cycloplegic, right? So we paralyze the ciliary muscles. This means there won't be any movement here now, no movement. So the blood clot won't break. So even if there's a bit of mydriasis from the atropine, in the case of Hyphema, it doesn't affect it that much. But here, because in Hypha, this angle was completely safe, protected, normal, just as it should be. But in this acute angle glaucoma condition, this angle is already closed like this. If it's already closed like this, and you give even a little bit of a mydriatic drug that pushes this iris forward, then the condition will get even worse. That's why we won't give atropine here. So atropine is also contraindicated in this. Diphenhydramine. Diphenhydramine is an antihistamine. We won't give this either because it also worsens the glaucoma condition. A client has undergone surgery for retinal detachment with gas bubble placement. This means the patient had retinal detachment and we performed surgery for it. After that, a gas bubble was placed. The doctor put a gas bubble inside the eye. Which position should the nurse maintain postoperatively? So, in the postoperative phase, what position will you give them? This question is asked very often. It's a favorite question of the board. So, what happens in this case? In most cases of retinal detachment, what happens is that the retina becomes detached. See, normally the retina should have remained attached like this. Look here, this retina, like this red part, is the choroid, and after the choroid, this green part I've shown is the retina. The retina must always stay attached to the choroid so its cells receive nutrition and don't get damaged. But as age increases, the vitreous fluid starts to shrink. Because of that, the retina will start to get damaged, and once damaged, it'll separate from this choroid. Separation from the choroid is called retinal detachment. Look, it'll happen like this. Now, this condition here is what we call retinal detachment. The doctor performed surgery for this, and after the surgery, he inserted an air bubble. Once he's put the air bubble inside, what position will you give the patient? That's what's being asked in the question. So, like, we have this air bubble. When we put an air bubble inside, you have to remember one thing. An air bubble will always go towards the top. It's the nature of an air bubble that no matter where or how you release it, it will always go up. Like in this bottle, there's air at the top and water at the bottom. You can probably see this. Now, if I say, look, the air is at the top again. If I turn it like this, now look. The air is at the top again and all the water has come here. If I turn it upside down like this, even then, look, the water's at the bottom and the bubble's at the top, meaning the air is at the top. If you can't see it, I'll remove all of this. Now look, the air is always at the top in this. Now when I did this, the air is still at the top and the fluid is at the bottom. If I turned it even more upside down, the air is still at the top and the fluid is at the bottom. If I do it like this, the fluid is still at the bottom and the air is at the top. This means that the nature of air is that it will always stay at the top. So now if I consider this as an air bubble, like I've taken this air bubble and doctor has inserted it so that it sticks back to it, the air bubble is here so that it keeps pushing it. It will keep pushing it back like this. If it keeps pushing it back, then this retinal will get stuck to it again. It'll stick. But if the doctor inserted it here and left it, and after that you gave the patient the Fowler's position, meaning if you gave the position I'm in right now, then it will go up, right? Because we just saw that the nature of air is to go up. So it'll stay here, which means it won't be able to push it back any further. So this positioning will not be effective. And in which positioning does this happen? If we look at this part of the eye, look at this. If the patient is in the Fowler's position, their head will be like this, right? So their eye will be like this. We've enlarged this eyeball, so it'll be like this in it. And mostly, you have to remember one thing. The most common site for retinal detachment is from the posterior wall. This means that instead of here or here, the retina will detach most in this posterior area. So what will happen now? If the patient is in the high Fowler's position and the doctor has inserted an air bubble, if we put the patient in the high Fowler's position, the sitting position, then what will happen? It will go up. This means it's not effective. So this means if there's a high Fowler's position anywhere in the options, we will eliminate it. Look, what's in option D? High Fowler's position? So this will be wrong. After this, let's see if we put the patient in the prone position. No, sorry, not prone, supine. In supine, what happens is that the patient lies on their back. Lying on the back means that their eye will be facing upwards. Now, if I look at this eyeball will be like this. And we had studied that the most common site for retinal detachment is? The most common site for retinal detachment is in the posterior area. This means that since the patient is lying on their back, their eye will be facing up, so this part is at the bottom. Since it's at the bottom, if we put the patient in the supine position after surgery, if we give the supine position and if the doctor has put air inside, an air bubble, and the nurse gives the supine position, then the air will go up because we've learned that the nature of air is that no matter where it goes, it eventually rises. It'll go up, which means it won't apply pressure on it, so the surgery won't be effective. This position won't be effective either. So now we have to eliminate the supine option from these choices. So supine is also incorrect here. Next is sideline. What will happen in sideline? Sideline on the unaffected side. If we lay them on their side, because of that, for example, if the patient is lying like this, the bubble will come to the top, while the retinal detachment is at the back, so it will remain unaffected. After that, face down or prone position. In the prone position, the patient lies on their stomach face down. So in this, the face will be downwards, face down and prone position. Now look, if we have positioned the patient like this, the eye will be facing down and the retinal part will be at the top. Now look here, if we show the eyeball separately, our eyeball will be at the bottom and the retina will move to the top. Now the air bubble that the doctor put in there, this air bubble, now look, no matter where you leave it, it will eventually go up. Now it will go up, which means it will push it like this towards the back. It will push it back or keep it stuck here, okay? So it will keep it attached like this here. So this retina will stick here like this, and this air bubble will keep moving further up like this. So this is our air bubble, and it goes, we'll leave it inside. So it will go here, okay? Now it will keep it under pressure, keep it stuck. So that's why after retinal detachment, we will give the patient the prone and face down position. So the correct answer here will be C. A child is undergoing eye irrigation at a school setting. Which action should the nurse keep in mind? Select all that apply. So what should the nurse keep in mind during eye irrigation? Place the solution directly into the center of the eye. Now, if we put it directly in the center of the eye, it will hit the cornea and damage it. So this is incorrect. Instill the solution into the lower conjunctival sac by pulling the lower eyelid downward. Yes, we'll pull the lower eyelid down and put the irrigation solution in the lower conjunctival sac. This is correct. Here, tilt the head toward the opposite eye. The opposite or unaffected eye. This means if, say, in this eye, chemical has entered, and it says we should position it over the unaffected eye. If we position it like this and then irrigate, the water or chemical will enter this eye too, contaminating it. So don't do this. We need to lay the patient on the affected eye. So this affected eye, if we wash it now, the water will flow down from here. So there won't be any problem with the healthy eye. So this will also be wrong here. Perform hand hygiene before the procedure. Yes, this is correct. Hand hygiene must be done. Irrigate the eye using sodium bicarbonate. We don't irrigate with sodium bicarbonate because we should never neutralize chemicals in the eye because that creates heat. Acid plus base will mix and generate heat, which will damage the cornea.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course. The link is in the description. Now, let's continue with the topic.
The nurse is caring for a client diagnosed with macular degeneration. This means the patient's macula has degenerated. That is, the macular part of the retina has degenerated. Which of the following images best represents the visual field associated with this condition? What does visual field mean? Visual field is whatever we see. The center one is the central visual field, and the surrounding one is the peripheral visual field. Now, in the previous question, we saw that, now this question asks which visual field, which image shows macular degeneration correctly. So 4 images are given here. Now, you need to note this. You'll understand everything from here. Cataract means there's a problem in this lens. A problem in the lens means peripheral and central vision don't matter. The entire visual field will be blurred. And then when there's damage here in the peripheral area of the retina, which happens in glaucoma, there's a loss of peripheral vision. And the macula, that is this yellow part, contains central vision cells. If this is damaged, the central area will become black and you'll keep seeing from all around. So now let's see first. In this image, that is among the 4 images given, this image, what do you see in it? That it's visible from the middle and completely blacked out from all around. This means the peripheral cells were all damaged and we can see the central things. So we saw this in glaucoma, right? That in glaucoma, the periphery, this area was getting damaged. This means this is an image of glaucoma. So this isn't macular degeneration. Look here, what happened in glaucoma? The IOP increased, the intraocular pressure increased here, so the lens pushed backwards, applying pressure here, causing damage, then here, causing damage, and then here. So the pressure goes back like this. So what does that mean for glaucoma? The peripheral cells of the retina get damaged, and because of that, there's a loss of peripheral vision. So that first image was of glaucoma. It wasn't macular degeneration because the macula is still intact in this one. Now, look at this second image. It's completely blurred. We already ruled out the first one because that's glaucoma. This second one is totally blurry. You can't see the central vision clearly, meaning we can't see the central visual field or the periphery. Both are blurred, and that happens in cataracts, because in cataracts, the lens becomes cloudy, and because of that, light rays can't reach any part of the retina, so this one is also incorrect. Next is the third one. Look at this. The center is completely blacked out, but we can see clearly all around it. This means the central area is damaged. So what's happening here? The macula is degenerating while the surrounding cells are perfectly healthy, which is why we can see the periphery. You should correlate this with, because we learned that the retina, this part of the retina, its peripheral area, controls peripheral vision. And the central area, this one, the macula lutea, controls the central vision. This means that's what's damaged here. So it's called macular degeneration. So the center's affected, meaning the macula degenerated. That's why there's a complete blackout right in the center. And since the question asked about macular degeneration, this is the correct answer. Now look at this one. It looks like a curtain is coming in from one side of the visual field, like someone is pulling a curtain across. This mostly happens in retinal detachment. In retinal detachment, as soon as the retina separates from the choroid, that part loses its nutrition, and without nutrition, the cells in that area can't send proper visual signals to the brain, making it feel like a curtain is moving into the visual field. So this one is also wrong. During a school workshop, a student suddenly screams in pain after a sharp object strikes the eye. On assessment, you see a penetrating object lodged in the eye. The student is anxious and attempting to move the eye. What should the nurse do first? Meaning a penetrating object has entered the patient's eye. Now, what will the nurse do first? Option A, remove the object carefully using forceps. We shouldn't remove it. If we try to grab and pull the object that went inside, it might go even deeper. It's possible that the surrounding structures inside the eye could get damaged. It's possible there could be bleeding, so we should never try to remove it. Anyway, it's not within a nurse's scope of practice. This falls under an ophthalmologist's scope, so we'll mark this as wrong. Ask the student to blink repeatedly to clear the eye. We won't tell the patient to keep blinking either, because the more they blink, the more movement there will be inside the eye and the more damage it'll cause inside. So this will also be wrong. Apply an eye patch to cover the injured eye. Meaning, we'll apply a patch to protect the injured eye. And this is where that same trap starts again, where some students think that this will provide protection, so we'll go with the patch, but that's wrong because you have to remember about the patch. The patch will go directly over the eye, and by going over the eye, it will directly touch the eyeball. So it's possible that as soon as we apply the patch like this, the object will be pushed even further inside. So we won't apply a patch, making this option wrong as well. Apply a protective eye shield to both eyes. Yes, the eye shield, this eye shield, has space inside it, so we'll apply it like this. If we've applied it this way, it means that we've gained protection from the front and that object didn't go any deeper because there's plenty of space. It's not touching it directly. It also mentioned one more thing, apply to both eyes. Why did they say both eyes? Because if we only apply it to one eye, look, the visual stimuli are gone from the front, so we can't see them, meaning this eye won't move. But if this eye is open, then suppose I'm looking at something and I'm moving it around, then my eyeball is moving around. And both of our eyeballs move together. If there are stimuli in this one, visual stimuli, and I'm looking at this while moving it around, my eyeball is moving from here to there. So along with it, this eyeball is also moving. That's why we have to cover both eyeballs so that there's no movement in either of them, okay? So the correct answer here will be to apply a protective eye shield to both eyes. A nurse is teaching a client about the correct use of prescribed ophthalmic drops and ointment, meaning the patient is being given both ophthalmic drops and ointment. Which statement by the client indicates correct understanding of the teaching? Select all that apply. This means it's asking for correct understanding, so we need to provide the correct statement. The correct statement will be our answer here. So the first option is, I will place the eye drop into the conjunctival sac. We'll put the eye drop inside the conjunctival sac. What is the conjunctival sac? When we pull this eyelid downward like this, the space that's created here is what we call the conjunctival sac. Like here, if we pull it downwards, this area will be called the conjunctival sac. So this is correct. This is a right statement. So that means we have to select this one. Next is, I will apply the ointment from the inner canthus to the outer canthus. What are these canthi? Canthus refers to the corners of our eyes, where the upper and lower eyelids meet on the inside, forming a corner, which we call the inner canthus. And where both eyelids meet on the outside, another corner is formed, which we call the outer canthus. If I show it here, like these are our two eyes, these are the two eyes. In this, where the upper eyelid and lower eyelid meet, this is the canthus, this is the outer canthus, same in the other eye. So these two are The inner canthys and these two are the outer canthi. Now, one thing you must remember is that from this inner canthus, a thin duct emerges, a tube, and it goes into the nose. Similarly, a duct comes out from the other side and goes into the nose. If we put all the medication in this canthus and leave it there, it will drain from here into the nose and get systemically absorbed, which will start showing systemic side effects. So in the statement, it said, I will start applying my eye ointment from the inner canthus and move it towards the outer canthus, right? So as it started from the inner canthus and stopped here at the outer canthus, this is the correct statement. Because, for example, we need to move away from the inner canthus while applying so that the medication doesn't exit through this drainage system and go into the nose. So that's what he said. So that means we have to go from the inner canthus to the outer canthus. Now this is also in the statement, so that means this will be its correct statement. I should instill the eye drop directly into the cornea. We should not put it directly into the cornea. If we put it directly in front of the cornea, like this, right here, if we put it into the cornea here, then the cornea, while the conjunctiva is over the cornea, these are delicate structures, so there will be chances of the cornea getting damaged. So we don't want to damage the cornea, so that's why we won't put it directly into the cornea. We will put it into the lower conjunctival sac. So this is its incorrect statement. After that, I will apply the ointment first and then instill the eye drop. We won't do that because, you see, eye ointment is thick and oily. When we apply it to the eye, it absorbs very slowly. It stays on for a long time, and it forms a cover over the eye and absorbs over a long period. If we apply the ointment first and then put in the eye drop, say immediately or 10 or 15 minutes after applying the ointment, then what will happen is that there's already a layer of ointment on the eye. So now when we've put the eye drop on top of it, it won't be able to be absorbed. But our eye drop really isn't that thick at all. Honestly, it's not thick, so it's definitely not very oily either. That's actually the reason why it gets absorbed into your eyes so quickly. So then what we do next is, we first give the patient the eye drop so that it gets absorbed quickly within 10 to 15 minutes, and after that, we'll apply the eye ointment. So they put the eye ointment first, which means this will be wrong here. We have to put the eye drop first, and then a little while later, 15 to 20 minutes later, or 15 minutes later, we'll put the eye drop in. I will close my eye tightly after applying the eye drop. That is, closing the eye tightly after putting in the eye drop. No, don't do it tightly, because if you close your eyelid tightly after the eye drop will be squeezed out, so we shouldn't do that. So this will also be wrong here. A nurse is caring for a client diagnosed with retinal detachment. That is, the retina has become detached from the choroid. Which of the following priority nursing interventions should be implemented first? So the priority action is being asked. Instruct the client to immediately restrict head and eye movements. So now what happens is that normally in our eye, there are these three layers. Like the outermost is the fibrous layer, then the red one I've shown is the choroid layer, which has many tiny blood vessels for nutrition. After that, this green one I've shown you is the retina. This retina stays completely stuck to this choroid. It shouldn't detach. If it does, it won't get nutrients from the choroid and the retinal cells will be damaged. So in retinal detachment, what happens is that this retina, normally, if I draw it like this, then this retina should have been like this, stuck to it. It should have been stuck. But what happens is it gets damaged here and ends up like this. So if it gets damaged in this area, this is what we call it detaches from the choroid. This is what we call retinal detachment. Now, the more the patient moves, this mostly happens because the vitreous fluid starts to shrink with age. Now, if it shrinks, this vitreous fluid won't be able to push it and keep it stuck. Normally, the vitreous fluid pushes it like this, so that the retina stays stuck to the choroid. With age, this vitreous fluid shrinks. It will shrink. So wherever it shrinks, it will pull it towards itself. It'll tug it. So the more movement there is, the more it will keep pulling. So that's why what we need to do. First of all, we must restrict movement. So the first option, instruct the client to immediately restrict head and eye movements. Yes, we must immediately restrict head and eye movement so that the retina doesn't detach any further. Initiate placement of a vascular access device. Vascular access device means an IV cannula. So right now, we don't need to insert an IV cannula. Because inserting an IV cannula won't prevent a retinal detachment from getting worse. Because the retina detaching, inserting an IV cannula won't be able to stop that detachment. Review the client's correct pharmacological therapy. So, reviewing what medications they're on would also delay our necessary action. Provide education regarding prescribed topical ophthalmic medication, meaning we'll educate them about the meds we're giving. No, doing that would delay our primary action. This would cause even more harm to the patient. A nurse is evaluating a client diagnosed with senile age-related cataract formation. Which clinical manifestation most strongly supports this diagnosis? This means we need to identify the sign and symptom of a cataract here. What usually happens in a cataract? Like this. Our lens contains a protein that we call crystalline protein, and this crystalline protein is neatly arranged in a specific structure. Now, it will be arranged like this inside it. So, if it's arranged this way, the incoming light rays are easily refracted here, then refracted by the lens, and after that, like first refracting here, then through the lens, they pass smoothly through them to the retina. Similarly, light rays from this side pass easily through this protein, through the protein inside the lens, and move forward smoothly. But with age, this protein denatures, and its arrangement gets disrupted. So, because the arrangement is no longer proper, the lens starts looking completely cloudy. So, whatever the patient sees ahead will be blurred vision. For example, suppose this was the protein inside. It was arranged before, but now some are on this side, some on that side. This means it's misaligned. This arrangement is not good. Now, if some light rays come, those light rays will hit this and go from here to there, even though they were supposed to go straight. Now, if a light ray comes from here instead of going straight, it will go this way. A light ray coming from here will go this way instead of that way. This means the refraction of these light rays will be very high. There will be scattering here. Now, these light rays came and went this way, even though they should have gone straight, but the protein is not arranged. Because it's not arranged, they go off in all directions, causing scattering. And because of this scattering, a patient with cataracts experiences glaring or dazzle. Even a little light causes great discomfort to the patient because the protein in their lens is not arranged. Due to that, all the light gets scattered. So this is what happens in cataracts. Now, in cataracts, peripheral and central vision are not directly involved because the parts responsible for peripheral and central vision in our eye are on the retina. You are often confused about whether there will be a loss of peripheral vision or central vision. So you must remember that the parts or cells that control central and peripheral vision are located in our retina. This peripheral part of the retina, this one right here, controls the peripheral vision. Vision means that our visual field includes everything I can see in front of me, both ahead and in the center. All of this is my visual field, but what is directly in front of the eyes, in the center, I will call that central vision, and for that central vision or central field, this yellow part I've shown on the retina is what controls it. This yellow one is what we call the macula lutea. It's a distinct spot, and we call that spot the macula. It is yellow in color. So the word used for the yellow color is lutea. So this macula lutea, the cells in this part are responsible for our central vision, the vision directly in front of us. Whereas this peripheral part, look at this side, this peripheral part of the retina is for peripheral vision. This means if there's damage here, within this peripheral retina, whether it's in the peripheral retina on this side, then we won't see things around us, but we'll see things in the center. Because here, our macula lutea region of the retina is intact. It's safe. Suppose if there's damage here in this macula lutea, then we won't see things in the center. Everything will look completely black in the center, while the peripheral area is intact. Whenever the peripheral area is intact, we'll see things all around, but we won't see things in the center. But in a cataract, what happens is that these light rays can't reach the retina properly at all. So this means light rays can't reach both places properly, both the periphery and the center, and because of that, the entire visual field becomes blurred. Okay, clouding of the entire visual field means it feels like clouds have gathered, so there will be a loss of the entire visual field. So now let's see what our answers are saying. The options: progressive loss of peripheral visual fields, Look, progressive loss of peripheral visual field. Now, wherever the names peripheral and central appear, you can rule those out because it's a cataract, which means it's related to the lens, and the lens has become completely clouded, so because of that, you have to rule out both peripheral and central. Loss of the peripheral visual field doesn't happen in this. Loss of the peripheral visual field will occur only when there's loss within the periphery of this retina, and when does this happen? Loss of the peripheral visual field occurs in glaucoma. Mostly it happens like this, because as the pressure increases here, as the aqueous humor increases, the pressure will increase, and the lens will push backwards. It will push the vitreous fluid, so pressure will be applied here first. The wave of this pressure will go and apply pressure here, and will apply it here. If the intraocular pressure increases further, it will apply more pressure here and apply pressure further back. If the intraocular pressure increases even more, then it'll apply pressure even further back, and if it applies pressure further back, it means these cells will get damaged. This means, and these cells of the retina are responsible for peripheral vision, if the pressure increases further, then it will keep getting damaged further back. And this means this area, which was responsible for central vision, is intact, but the periphery is damaged. So this is seen in glaucoma. So this means this symptom is of glaucoma. This one will be in glaucoma, because in glaucoma, we saw progressive loss of peripheral vision, meaning we can't see around us. If we can't see around us, it means it feels like the person is looking through a tunnel, which is why we call it tunnel vision. So when glaucoma occurs, in glaucoma, the patient experiences tunnel vision. So this first option is incorrect because cataract does not cause tunnel vision. Next is the gradual deterioration of central vision or central visual acuity. Now, regarding central visual acuity, it means you can't see things in the center, but you can see everything around the periphery. This loss of central vision mostly occurs when this specific part is damaged, the macula lutea, while the periphery remains intact. But as for cataracts, not cataracts, if the macula lutea is damaged, it means the central visual field is affected, so we won't see anything in the center, but the periphery remains visible. This happens in macular degeneration. Whenever macular degeneration occurs, the cells in this area, called the macula, degenerate. When cells in the macular area degenerate, the disorder is called macular degeneration, and central vision is damaged. So this gradual and progressive deterioration of the central vision typically occurs in a condition known as macular degeneration. It's something that is commonly found in cases of macular degeneration, so this is also considered to be the wrong answer. The next option is impaired night vision, particularly during driving. The patient can't see well at night, meaning their vision is affected, especially while driving. Why does this happen? Well, during the day, our pupils constrict slightly because there's so much sunlight. The pupils stay constricted, so less light enters. At night, it's dark all around. To see objects clearly, our pupils dilate so that more light can enter. So at night, the pupils are dilated, letting in more light. But when the patient drives, the light from oncoming vehicles hits the lens and scatters. This causes a blinding glare all around, and the patient can't see. This is a major problem and a key symptom for these patients. Because at night, the pupils are dilated, more light from oncoming cars enters. Then, because the proteins in the lens are degenerated or misaligned, scattering occurs. This means the patient has significant difficulty seeing while driving at night. This is commonly seen in cataracts, so this is the correct answer. The last option is blurred vision associated with headache. While the patient will have blurred vision, it won't be with a headache. Cataracts are painless, whereas glaucoma is painful, so headaches are seen in glaucoma. You must remember that pain occurs wherever there is pressure on a nerve. In cataracts, there's no pressure. It's just a lens abnormality. If headache wasn't mentioned, we might consider it. But since it's blurred vision with a headache, it's not a cataract symptom.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course. The link is in the description. Now, let's continue with the topic.
A client receiving intravenous Mannitol for glaucoma suddenly develops confusion during the infusion, meaning we're giving IV Mannitol to a glaucoma patient and they suddenly become confused. So, what's the nurse's first priority action? So, to understand this, we need to see why in glaucoma. Why is Mannitol given? Mannitol is an osmotic diuretic, meaning through osmosis, it pulls water into the blood vessels. It pulls it in. Now look, normally we have these blood vessels. Inside these blood vessels, if we give more Mannitol, what happens? Water starts collecting. Water starts flowing into the blood vessels. How? Like when we give Mannitol to the patient, it enters the blood vessels. Now, suppose there's already sodium and potassium in the blood vessels. Sodium here, potassium here. Now, we've given the patient Mannitol. I'm writing Mannitol as M. So that means Mannitol is in the blood. And Mannitol is hyperosmotic, which means it will thicken the fluid inside this blood vessel, or it will increase its osmolarity, or the concentration will become higher. This means the solute concentration is higher in it. Now, what will it do? It will pull water from the cells on the outside, around the blood vessels. It will pull this H2O, the water. If Mannitol is given, then water will go towards the thicker fluid. That means osmosis will occur. So now water will come into it from here, and then water will come into it from here again. So similarly, what will happen when we've given the patient Mannitol? What will this Mannitol do? It will go into the choroid inside our eye, and there, the increased pressure in glaucoma, how does it reduce it? It will pull water from the vitreous fluid back into the blood vessels. Because of that, the volume of the vitreous fluid will decrease, so the pressure will decrease. Because of that, there won't be damage to the optic nerve. But what will happen with this? Now, for example, it's working for the glaucoma in the patient. But now if there's more Mannitol, it means it's thick. Here, this blood, it has become very concentrated. Now this is the brain. There are cells inside the brain too, and compared to the water in the cells inside the brain, there is less water in this blood vessel. If there's less water here, it means the blood is thick here. If it's thick, then through osmosis, now it's water that will come from the cells here into the blood vessel. Water from here too will come into this blood vessel. Water from here too will come into this blood vessel. Now that the water's out, it means these cells will shrink. They'll become smaller compared to before. They will shrink, and because of this, neurological symptoms will start to appear, such as confusion, headache, and the patient might even have a seizure if we don't stop this medication. So now, look, if the patient starts experiencing confusion or a headache, it means you should understand that the glaucoma medication was working in the eye, but it started pulling water from the brain cells into the blood vessels, causing the brain cells to shrink. This means neurological problems have started now. So the patient might have a seizure. So now what will we have to do? In such a condition, we will have to withhold this drug. Because this isn't a normal condition. It's not a normal thing. So continue the infusion? If we continue, the patient will have more neurological issues and symptoms might appear. So this is wrong. Slow the infusion rate? Slowing the rate might reduce the symptoms slightly, but we can't completely avoid that complication. Stop the infusion and notify the provider. Yes, we must stop it and inform the doctor. Reassure the client? By reassuring, we'll only waste time and not solve the actual problem. A nurse is caring for a client who has sustained a chemical burn to the eye. Which of the following actions should the nurse take first? This means a chemical has entered the patient's eye. So what will the nurse do first? You must remember that whenever a chemical enters a patient's eye, the longer it stays on the conjunctiva or cornea, the more damage it will cause. So our main purpose is to dilute it and get it out or wash it out so it doesn't cause more damage. The longer the chemical stays on the eye, the more damage it causes, so we need to shorten that duration. Apply an eye patch? If we apply an eye patch, the chemical won't come out. It will stay inside on the eye. This means this action is not good. Irrigate the eye with normal saline. Yes, now we need to irrigate the eye so the chemical washes out. This is the correct answer. Assess visual acuity? There's no benefit to checking visual acuity because if the chemical's still in the eye, it will keep causing damage, so don't check visual acuity now. That can be done later. We're being asked for the first action, the priority action. Administer analgesics? If we give the patient analgesics, we're delaying the irrigation, which we must not do. So we must irrigate if a chemical has entered the patient's eye. A student in a school laboratory accidentally splashes a chemical into one eye. The nurse plans to irrigate the eye immediately. Which solution should be used initially? This means a chemical has entered the patient's eye, and the nurse is now planning which solution to use for irrigation. But you must remember, a condition is given here. They've specified a school laboratory. The patient is in a school, not a hospital, so what fluid would you use first, initially? Normal saline is option A, and most students choose this option, but that's where they go wrong. This is a classic trap designed to catch you, because normal saline isn't necessarily available outside a hospital, and we can't wait for it to arrive because the corneal will get damaged, so this is wrong. In a hospital setting, you could use normal saline because it's an isotonic fluid, which is an ideal solution, the best solution for eye irrigation, but that's only if it's available, mostly in a hospital setting. However, in a school or any non-hospital setting, if normal saline is there, fine. If not, you shouldn't wait for it. Just clean it with water, which is easily available everywhere. Now, for sodium bicarbonate, students sometimes select this and fall right into the NCLEX trap. They might think that if an acid got into the eye, then using a base, if an acid went in, we can neutralize it with a base and it'll be fine. No, don't do that, because if there's acid in the eye and it reacts with a base, it generates heat, and the more heat generated on the cornea, the more the cornea will be damaged. This means we should not irrigate with sodium bicarbonate, since doing so can make the soil too alkaline and negatively affect plant health. Water, yes, water is easily available, so it will dilute the chemical and wash it out. This reduces the chemical's potency, its strength, and its overall effect. Sterile distilled water. Where's distilled water? Available in a school? So we'll mark this one as incorrect too. A client suddenly develops severe eye discomfort and presents to the clinic. The provider diagnoses acute angle closure glaucoma. This means it's acute angle glaucoma. Which symptom should the nurse expect? Meaning, what symptom will the nurse expect? So if it's acute angle glaucoma, what does glaucoma actually mean? Yes, glaucoma means glaucoma. You have to understand it this way. In our eye, there's an angle right here between the iris and the cornea. A canal passes through this angle that drains the aqueous humor, the aqueous fluid formed here, and there's a trabecular meshwork right here. The more open this angle stays, the better the drainage will be. As soon as this angle closes, it means there's an obstruction here now. This fluid will collect here, it'll build up right here, and then it'll push against the back. When it pushes, the pressure in the eye increases. This is what we call an increase in intraocular pressure, and this is what we call glaucoma. So now what's being asked here is which symptom is related to glaucoma? A. Gradual painless vision loss. Now, one thing you need to keep in mind is that if the pressure is increasing, it means the pain receptors will be pressed, they'll be compressed, and that will cause pain. If it's glaucoma, it means it won't be painless. So you can, and since acute is given here and gradual is given there, you can eliminate it based on that too. But the most accurate way to look at it is that there is pain in glaucoma because the pressure increases there, and wherever there's pressure on a nerve, there's pain. That means it won't be painless. Painless vision loss occurs in cataracts, so we'll eliminate this option. Next, B, severe eye pain with halos. There will be eye pain because the pressure is rising. Now, we need to see whether there will be halos or not. A halo means that when we look at any object, we see something like a circle of light around it. Now, why does that happen? Let's first look at what happens normally in your eyes and mine. After that, we'll find out if halos occur or not. In glaucoma, look, this was our cornea. Now, as the aqueous fluid is formed here, meaning the aqueous fluid from the ciliary body, which comes from behind the iris to the front into the anterior chamber, it then goes through this angle into the canal of Schlemm and into the systemic circulation. But at that time, along with that, this fluid also enters the cornea. Coming into the cornea? Now, once it enters the cornea here, what will it do? It'll be put back into it. Now, there are some pumps here that we call sodium-potassium pumps. We call these sodium-potassium ATPase pumps. What will happen with this? Now, sodium goes out from here into this, meaning it will come here. As sodium comes, water will also come back here along with it. Now, this water, the aqueous humor, will drain out again. This is the normal process. Let's understand it once more. When aqueous fluid is formed from the ciliary body, it spreads forward into the entire anterior chamber. After that, all of it exits through this canal of Schlemm. But along with this, water from this aqueous humor also enters the cornea. And after staying in the cornea for a short time, it goes back out. Because on this cell, meaning this inner layer of the cornea, sodium-potassium pumps are found. Now, sodium comes back into this inner chamber, so water comes back out with the sodium through osmosis. So this is the normal process, and because of it, there's no swelling in the cornea, meaning the cornea doesn't swell. But what happens in glaucoma is that this angle closes, meaning either the iris moves backward, so if we assume the iris has moved backward like this, then this angle is closed. Now, if the angle is closed, then look, this aqueous fluid won't be able to drain from here. If the aqueous fluid can't drain from here, then all of this aqueous fluid will collect right here. Now, the pressure here will increase, the pressure inside the anterior chamber will rise, and this pressure will continuously keep increasing. Now, the higher the pressure, the more it will damage these sodium-potassium pumps, meaning it will damage the sodium-potassium pumps found on the inner layer of the cornea. And as soon as the sodium-potassium pumps are damaged, then the sodium won't be able to get out, and if sodium doesn't get out, it means water won't get out either. But water was going in, right? Because the water going in was due to hydrostatic pressure, meaning the water pressure here is low and the water pressure here is high, so water was going in. After going in, when sodium was coming out, it was coming out with it through osmosis. Now that won't be possible. Water is coming in because water doesn't need the sodium pump, the sodium-potassium pump, to enter. It needs pressure. Now, the higher the pressure, the more water will keep coming in. But to get out, it needs the sodium-potassium pump. Now, the sodium-potassium pumps have been damaged due to glaucoma because pressure has been applied here for a long time. Now, this water will collect right here inside. Right here. Water will collect inside here, so look, this water will remain here. Now, water will remain collected inside this cornea. Now, this cornea will swell up. Okay. As the cornea swells, it means water has been retained inside it. Water has been retained right here. So now, as the light rays were coming from here, let's say these light rays were coming now from here, it will cause them to scatter right from this point. Okay. Now, it will scatter it like this. Initially, it was passing through normally like this, okay? It refracts a bit, I know, because the most refraction happens on the cornea. 75% of light refraction occurs on the cornea and 25% on the lens. Refraction means like when light rays come, suppose light rays hit the cornea like this, then they will refract. But they will pass through properly. But in this case, what happens is that the water droplets will now block it. It'll block it and scatter it around. It will cause abnormal refraction, so because of that, what will happen? Around the object, it will seem to us as if there's a circular structure formed, which we call a halo. That happened because the cornea became swollen. Inside the cornea, the water droplets are collected. On those drops, as soon as light hits here, it gets refracted from here in an abnormal direction, and because of that, it will seem to us as if any object has a halo around it. Suppose we see that this cornea normally works like this sponge. This sponge, if we look at it from this side, will normally function like a sponge. Now, what will happen? Suppose we poured water into it like this. If we poured water over it like this, it would absorb this water first. Sorry, some water spilled out, but suppose we poured water over it like this. The water is going into this sponge now. The sponge is absorbing it. Now there isn't much pressure on it. Now, as soon as it's squeezed, the water comes back out. Now look, as we're squeezing it, on this side, see the water came back here. It didn't come out on this side, it came out on this side. So normally what happens is that as water comes out of the sponge, it's because we're able to squeeze it. If we don't squeeze it, the water will keep being retained inside, and it will become completely swollen. The same thing happens in glaucoma, and in glaucoma too, what will happen is that water will start being retained. Because of that, there will then be abnormal refraction of the light rays with the water droplets that are there, and because of that, a halo will then be seen. So that means in glaucoma, there will also be a halo. So now let's see what's given in the options. Severe eye pain with a halo. Eye pain occurred because the pressure is increased and a halo will also be present. So that means this will be the correct answer here, option B. So this will be the correct answer here. Next is central vision loss. Central vision loss means the macula must degenerate for central vision loss to occur. But we saw that when pressure increases here, it first damages the peripheral retina. This means there will be peripheral vision loss, not central vision loss, because tunnel vision occurs then, right? Because in glaucoma, tunnel vision occurs. Tunnel vision means the things in front will be damaged, they won't be visible, but the things around them will be visible. The peripheral ones will be visible. Because in this, in this, what will happen is that we will see the central things because the macula is intact, but the peripheral things won't be visible because the peripheral part of the retina has been damaged. So that means here it says central vision loss. Central vision loss doesn't happen. Central vision loss will occur in the condition of macular degeneration. After that is floaters and flashes, floaters and flashes. As we saw in the previous question, these occur in retinal detachment, so this option is also incorrect. A nurse is providing discharge teaching to a client who has just undergone cataract surgery. Which action should the nurse instruct the client to avoid? So after cataract surgery, which action should we tell them to avoid? Bending forward. If they bend forward, the IOP will increase. So this is the correct answer. We must tell the patient not to bend forward. So this is correct. Next, watching television. Watching TV might cause some slight strain, but it's generally okay. Then wearing sunglasses. That's a good practice. Reading a book. This also won't significantly increase the IO pages. We need to avoid activities that raise IO pages. Bending will increase IOP, so we must ensure the patient doesn't bend. Next, a nurse is conducting a comprehensive ocular assessment on a client in an outpatient setting. Which of the following instruments should the nurse utilize to evaluate the client's visual acuity? Visual acuity. Acuity means sharpness. It's how clearly a patient sees at a fixed distance. So, what do we use? A Snellen chart. Yes, we use the Snellen chart to measure visual acuity. If you want to see it, this is the Snellen chart. This is how we determine the patient's visual acuity. The next option is a tonometer. A tonometer is used for IO pages. It's used to measure intraocular pressure. If you look, it looks like this. We're assessing visual acuity, and that's not done with a tonometer, so this is incorrect. Next is a pen light. A pen light is used like a flashlight to examine the eyes. We use it to see if the pupil is reactive and to check its size. So this is also wrong. A slit lamp is used to examine the internal structures of the eye. This is the pen light, and this one is the slit lamp. A client reports suddenly seeing flashes of light along with multiple floaters in the visual field. What is the nurse's priority action? When a patient has flashes and floaters, what's the first thing a nurse should do? We've learned that floaters or flashes indicate the retina is starting to detach. We must minimize the patient's movement because movement causes the vitreous fluid to shift, which pulls on the retina even more. If it pulls, it causes more damage, so we must limit movement. First, reassure the client. Reassuring them won't stop the detachment, so this is wrong. Apply prescribed eye drops. Eye drops also won't prevent further retinal detachment, so this is incorrect. Notify the provider immediately. Yes, we must inform the doctor right away so they can take action. This is the priority. Cover the affected eye. Covering the eye won't help once detachment has started, so notifying the doctor is essential. A nurse is teaching a client who's been diagnosed with glaucoma. This means their intraocular pressure is high. Which statement by the client indicates a need for further teaching? Since it says further teaching, it means the incorrect statement will be our answer. So it is glaucoma, and we need to find the incorrect statement. I will use my eye drops daily? Yes, that is a correct statement. I can stop drops when vision improves. I can stop my eye drops when my vision improves. Now, even if vision improves, you cannot stop the eye drops because vision might improve for a short time after starting them, but treating glaucoma requires long-term treatment over a long period. So you cannot stop it. This is the incorrect statement, which means this is the answer here. This condition can cause blindness. Yes, if timely treatment is not taken properly, blindness can occur because the increased pressure damages the optic nerve, leading to blindness. I need regular checkups. Yes, the patient needs to have regular checkups. A nurse is administering Timolol ophthalmic drops to a client with glaucoma. Timolol, that means it is a beta blocker. Anything ending in olol is a beta blocker. To the client with glaucoma, meaning the intraocular pressure is high, so we have given Timolol to reduce that pressure. The client has a history of asthma and bradycardia. Which action by the nurse is most important to prevent systemic effects of the medication? So the patient has glaucoma with high IOP, and we have given Timolol so that the intraocular pressure decreases. But the patient also has asthma and bradycardia at the same time. So now, what action should we take so that there is no effect on the patient's asthma and bradycardia conditions? We must remember that any beta blocker medications will constrict the bronchioles and cause bradycardia. So if we are putting eye drops in this patient and they go through the nose and get systemically absorbed, it will cause bronchial constriction in an asthma patient. This means the asthma condition will get worse. In a patient with bradycardia, it will worsen the bradycardia, meaning that condition will also deteriorate. So we need to prevent systemic absorption. Instruct the client to blink rapidly after installation if the eye drops are administered. And then we tell them to blink their eyes rapidly. That action is not effective for preventing systemic absorption. Wipe excess medication from the eyelids immediately. This also does not stop systemic absorption. Ask the client to keep the eye tightly closed after installation. We should not have them close it tightly. It should be closed gently, because if they close it tightly, the medication will leak out. So this is also wrong. After that, apply gentle pressure to the nasolacrimal duct for 1 to 2 minutes. Yes, the nasolacrimal duct, which starts near the inner canthus and goes into the nose. We need to apply pressure here for 1 to 2 minutes, gentle pressure, so that systemic absorption does not occur. The drops do not enter the duct, and the medicine stays only inside the eye. A nurse is providing discharge teaching to the client who has been prescribed atropine. Atropine has been given, which means it is a cycloplegic and a mydriatic. This means it'll dilate the pupil and it'll also paralyze the ciliary muscles. The nurse emphasizes the safety precautions related to this medication. Which instruction is the most important for the nurse to include? This means it's a mydriatic. It will dilate the eyes. Plus, atropine is a cycloplegic. It's a cycloplegic, which means it will paralyze the ciliary muscles. This means our eye will no longer be able to accommodate. If it can't accommodate, it means we won't be able to see distances or potholes clearly. So now you have to keep this in mind. Use the drops only when eye pain occurs. It's not given for pain. So this one is wrong here. Store the medication in the refrigerator. This isn't something particularly important to keep in mind either. Avoid driving or operating machinery after use. Yes, if we suppose we have given the patient a mydriatic, like atropine. It also acts as a cycloplegic. So for one, their eyes are dilated, and after that, the accommodation we need to see distance, to see potholes, to see height, or to judge speed, we have to make the eyes accommodate. In that, the lens moves up and down, meaning it changes its size. And that happens because of the ciliary muscles. It happens due to the contraction and relaxation of those ciliary muscles. So that won't be possible now. If it's not possible, the patient won't be able to see well, so the patient might suffer more harm, and there are chances of an accident. So this means we have to tell the patient that you must not drive and you must not operate machinery. So this will be the correct answer. That's why we're looking at safety, because it asked about safety, right? We have to give a safety precaution. So these two aren't about safety, but this one explains safety well. Apply the drops more frequently for better effect. No, you should apply only as much as prescribed. Why apply more? A nurse is caring for a client who has been using corticosteroid eye drops for several weeks to manage ocular inflammation, meaning to reduce the inflammation inside the eye, the patient has been given corticosteroid eye drops. During a follow-up visit, the nurse plans appropriate monitoring for potential complications, meaning the nurse is looking for which complication might occur. Which finding is most important for the nurse to monitor? Meaning, when a patient is being given corticosteroids, what complication can arise from that? If we have given the patient corticosteroids for a long time, then decreased intraocular pressure. Intraocular pressure will not decrease because if we have given corticosteroids, it might cause the intraocular pressure to increase. It doesn't decrease from this. And if so, then this is not it. Increased tear production, this is also not related to corticosteroids. After that, improved night vision. It doesn't improve night vision either. After that is increased intraocular pressure. Yes, this complication here, increased intraocular pressure. Then we can assume that if the patient, let's say, didn't have increased intraocular pressure before, and if it has increased now, we can assume that our corticosteroid is causing side effects, meaning complications have started. Now that complications have started, how does this happen? Look, let's understand this. If corticosteroids were given for a long time to reduce swelling anywhere in this eye of ours, then what happens is that in this anterior chamber, there's aqueous fluid. Within this aqueous fluid, after some time, what happens here? Phagocytosis occurs. There's a type of white blood cell called a phagocyte, and what it does is, let's say some debris appears here, the phagocyte consumes and destroys this debris. They perform phagocytosis, and because of that, this trabecular meshwork remains open and completely clear. If it's clear, the drainage of aqueous fluid from here will allow it to easily enter the systemic circulation. So in this case, there's no chance of intraocular pressure increasing. So intraocular pressure won't increase here. Suppose in you and me, or any normal person, what happens is that it's necessary for this trabecular meshwork to stay open so that the fluid that came out, the aqueous humor, can go back through it into the systemic circulation so that the intraocular pressure won't increase and glaucoma won't occur. But when we give steroids to a patient for a long time, what happens is that the debris won't be destroyed. In you and me, what happens is, who is destroying the debris forming in this aqueous fluid? That debris comes and settles down here, but the phagocytes, which are a type of white blood cell, will consume them through phagocytosis. They'll eat them up. This means what will happen here? This trabecular meshwork will remain completely intact, so it means the pressure won't increase. But when we've given a patient corticosteroids for a long time, while their job is to reduce swelling, they also decrease white blood cell functions. One function of white blood cells is phagocytosis, destroying debris. So what happens is they won't be able to destroy the debris because the corticosteroid has reduced white blood cell function. Now this debris starts accumulating here. If debris accumulates here, it means it has jammed, blocked, or stopped the trabecular meshwork. Now the aqueous fluid that was being produced here won't move forward. If it doesn't move forward, it will stay collected right here. If it stays collected here, it means the pressure will increase. An increase in pressure inside the eye is called increased intraocular pressure, which we call glaucoma. So this means if we've given a patient steroids for a long time, the patient might develop glaucoma. Therefore, if the intraocular pressure has increased, we can assume it might be a side effect of the long-term corticosteroids. So this will be the correct answer here. The nurse is assessing a client and observes drooping. Drooping means falling downwards of the left eyelid. The eyelid falling downwards. How should the nurse document this finding? So how would you document this downward drooping of the eyelid? Mydriasis? No, mydriasis is the dilation of the pupil. Ptosis? Yes, ptosis is the drooping of the eyelid. Presbyopia. Presbyopia means opia is related to vision. Presby is related to old age. So with age, when a patient has difficulty seeing things up close, that's what we call presbyopia. So this will also be wrong here. Hyphema. We've already seen hyphema. Hyphema is related to the collection of blood in the anterior chamber of the eye. So this will also be wrong here. A client using Timolol eye drops develops shortness of breath. What is the nurse's priority action? Meaning, when a patient is given Timolol eye drops and develops shortness of breath, what will the nurse do first? Now, regarding Timolol, you must remember it's a beta blocker, and beta blockers, if their systemic reabsorption is high, will always constrict the bronchioles. And if the bronchioles constrict, it leads to shortness of breath or breathing difficulty. So, reassure the client. Reassuring won't solve the problem, it'll just keep getting worse. Continue medication. If we continue, the patient's breathing difficulty will increase. Hold medication and notify provider. Yes, we must withhold the medication and inform the doctor. Administer next dose early. No, that's also wrong. A nurse is reviewing the medication list of a client diagnosed with angle closure glaucoma. Angle closure glaucoma. Glaucoma means intraocular pressure is increased, and the type here is angle closure. This means this angle between the cornea and iris has closed up. This angle that was open before is now closed. This angle that was open before is now closed. So now this is angle closure glaucoma. Which medication should the nurse question? This means out of the medications prescribed to the patient, which one was prescribed incorrectly so she can question the doctor about why it was prescribed. So pilocarpine. Pilocarpine is a miotic. Miotics mean they constrict the pupil. And for medications that constrict the pupil, when the pupil constricts, now look at this. If this pupil constricts, like this pupil here, this area is what we call the pupil, right? The area in the middle of the iris. When this constricts, the iris here will naturally be pulled to this side. If it's pulled forward, it means the angle will open up. So we can actually give miotics. This means miotics are not contraindicated. Mydriatics are the ones that are contraindicated. So pilocarpine is a miotic medication, so we can give it. And in this question, we need to identify the medication that we cannot give. So this is wrong here. Timolol ends in lol, which means it's a beta blocker. And as a beta blocker, Timolol will act on the ciliary body here to reduce the production of aqueous humor. So this also prevents pressure from rising in glaucoma, meaning we can give this too. But the question asks for what we can't give. Next is atropine. What does atropine do? Atropine is a mydriatic, meaning it dilates the pupil, and it's cycloplegic, meaning it paralyzes the ciliary muscles. But as we saw, if this dilates even more, if the pupil dilates further, it means the iris will move even more to the side. Now the iris will move to this side, which means this angle will close even more, and we don't want the angle to close further. So atropine shouldn't be given to a glaucoma patient, and this will be the right answer here. Now, what is acetazolamide? Acetazolamide is another name for Diamox, and it also reduces intraocular pressure, so we can give this to the patient too. But here we need to identify the medication that cannot be given, so this would be the wrong answer. A nurse is providing education to a client who has been using Latanoprost eye drops for several months to manage glaucoma. That is, for a glaucoma patient, we've given Latanoprost to lower intraocular pressure. Which findings should the nurse expect with long-term use? Meaning, if the patient has been on Latanoprost for a long time. So which finding is expected? Which side effect is expected? Increased intraocular pressure? No, we gave it to reduce pressure, so how could it increase? Pupil dilation? It doesn't cause pupil dilation either. If it caused dilation, we wouldn't give this medication at all, because medications that cause pupil dilation are contraindicated in glaucoma. Severe eye pain? If eye pain increases, well, it's not really related to eye pain because it's given to reduce pressure in glaucoma. This means the pain should also decrease, not increase, so this isn't expected either. Permanent eye color change, meaning the eye color changes permanently. Yes, this can happen. This will happen because when we give Latanoprost to a patient for a long time, it increases the activity of melanocytes in the iris of the eye, leading to increased melanin production. If melanin production increases, our iris will turn dark brown and will permanently stay that color. So this is its expected side effect. It will cause a permanent eye color change. So this will be our correct answer. Last question. A nurse is providing discharge instructions to a client who has been prescribed Timolol. Again, that's a beta blocker because it ends in lol for glaucoma. Which instruction is most important for the nurse to include? Meaning, which instruction will we include in our health education if a patient is given Timolol for glaucoma? Use the drops only when symptoms occur? No, don't do that. Don't wait for symptoms to give the medication. It's been prescribed, so it must be given according to the schedule. So that's wrong. Monitor the pulse regularly. Yes, if a patient is being given Timolol, we must monitor their pulse because Timolol is a beta blocker. And if a beta blocker drop, for instance, gets absorbed through the nasolacrimal duct and enters the nose, leading to systemic absorption, then what will Timolol do? It has two actions. It either causes bronchoconstriction, which would be problematic for asthma patients, or it causes bradycardia. This means we need to monitor the patient's heart rate to see if bradycardia has occurred or if there's been systemic absorption. So this will be the correct answer. Avoid direct sunlight. It doesn't cause photosensitivity. It has nothing to do with this. Increased fluid intake? No, that's not related to this either. So, those were our 30 most important questions for today. And now we'll do 30 questions daily, covering each topic one by one. And in this upcoming 100-day challenge, we'll cover 3,000 questions. So this is a kind of challenge. You need to take our classes continuously for 100 days. After that, those 3,000 questions will be right at your fingertips, and you can pass the exam on your very first try. See you tomorrow in a new episode. Thanks.